Hi everyone, happy Friday. If you read the email, you noted that instead of Reza, we have Ethan today, and I find it very, very fitting because as we talked about before, I think we all love Reza for his dedication to the space and the enthusiasm he brings for it. But I don't know if anyone can match the dedication and enthusiasm of somebody who's willing to discuss at 1 a.m. Um, and so I think Prof. Rez would be very, very proud to have Ethan stepping into his mold. But the reason Ethan is here is not necessarily because of that, but really it's symbolic of it. This space, the Friday space, has become a place to recognize the long-standing dedication of some of our team members who have really been part of CP Solvers for a while and are changing the landscape. And last week it was Parisa, and this week it's Ethan, both of whom have recently been part of the VMR leadership team. And that is no small feat. That means that they have been working really, really hard to be influencers in this space, not just medically, but also in terms of setting the culture to commitment, dedication, community. And so I find it very, very fitting to honor and celebrate Ethan in the way we're going to do that today. Um, and so I'd love to hand the mic to you, Ethan, to say hello, and then we'll rally up the troops of everybody else who's part of this effort.
Yeah, thank you for the kind words, Robbie. And I feel like joining Academy is probably one of my highlights in the year of 2024. I feel like it blossoms my interest and love for clinical reasonings and medicines. So overall, we just really appreciate and happy to discuss and learn another case in the VMR. Yeah.
Wow, you're off to a great start. A full complete sentence at 1 a.m., a feat I have never been able to accomplish. Congratulations. Well, I think it's also really fitting to tell you who's scribing today because we had a last minute schedule change, and our fearless leader, the one and only Shema, has jumped in to scribe just like the good old times of 1863, if my memory serves me correctly. Shema, I don't know if you can unmute. Your video's off, so I'll just wait for 1 second to see if you can. Oh, there you are. Do you want to say hi? And you haven't subscribed for a long time. Do you want to update people on your life and what's new? Oh, I see. Okay. The answer is no. I'll tell you, Shayma's crushing it. Shayma's soon gonna be, Shayma's now a leader in VMR. She is a core part of the subspecialty series. And if you want to, subspecialty VMR series on Mondays, but if you want to hear her voice, you should check out the most recent space learning episode where she makes her debut on the podcast. Uh, Thank you, Shema, for scribing. And I don't need to tell you who's doing teaching points on Fridays. It's become a custom now. Hasha, hello.
Hi everyone. Yeah, I hunt down the Friday sessions. It's like the best time for me.
That's amazing. What's your week been like?
It's been a kind of an okay week.
Yeah.
Radiology rotation. I had
Mm.
an exam tomorrow. It got canceled.
Oh,
Kind
there
of
you go.
happy. Yeah.
Yeah. I was hearing that you have exam phobia, which I didn't know about you, but I think geez, yeah, now in my life I only have to take an exam once every 10 years, I think, to recertify. And I'm so glad. It used to be, the high school that I went to in Pakistan was so intense. We actually had an exam every day, every single day. And so I just kind of grew a little bit lulled to it. So, yeah. Anyway, I don't want to revisit that trauma. It's all in the past. Excited to have you here, Khashar. Thank you for doing the teaching points. I think you'll have a lot of work to do because we've been waiting for this case for a long, long time. I'm very, very excited to share the discussion seat with Ethan, especially because Leah is presenting. And Leah, like Shema, has been part of VMR since ancient times. And we're very, very happy that we get to have you here, Leah, again. So maybe you can update folks on what's new in your life and yeah, maybe that'll give them a little bit of a hint of what we are expecting, maybe or maybe not. But I'll hand the mic to you to say hello.
Hi guys, my name is Leah and really glad to be here. Um I would almost wanted to say a medical student from Austria, but I'm not a medical student from Austria anymore. Now I'm an intern because I think the last time I introduced myself here, I said I'm a medical student. But no, I started intern year a couple of months ago.
那个好
And
多饺子和包子。
I'm doing rheumatology as a specialization. So the system here is a bit different. So basically the beginning is still very general internal medicine training, but you already choose your specialty. So I'm really excited that I get to learn a lot about rheumatology and internal medicine in general as well. So that's what's kept me busy and excited the last few months. And the case I'm presenting today is actually a case I saw in one of the first weeks of intern year. So excited to share this with you and yeah, hear your discussion. I'm sure, Ethan, you're gonna do an amazing job today.
Super excited, Leah. All right, why don't we rock and roll?
Okay, let's start. So today we have the case of a 56-year-old male of a man who presents with dyspnea and spine pain. And a bit more history, he's had cough and dyspnea for around 10 days with whitish sputum, he says, but no fever. Additionally, he has experienced weight loss of about 8 kilos unintentionally in the past year and increased fatigue and pain in the sacral region for about 3 months. And he presented to a hematology clinic around 3 months ago as well, due to thrombocytopenia. He had a platelet count of 41, and they didn't really find a concrete diagnosis. It was termed ITP, quote unquote. And there was also an isolated AP, so alk phos elevation, found on labs. Now, with these two labs, hematology was concerned for malignancy, and they recommended a pelvic imaging, or no, a pan imaging, so top to bottom, basically. And that's the first aliquot.
Oh my gosh, Ethan, what an explosive start. Maybe we can take this piecemeal. Maybe we can just really start authentically to what we might have heard with what were your first thoughts when you heard the cough and the dyspnea for 10 days? And then we can try to see where that takes us and analyze the rest of the data.
Yeah. So it's interesting because I think recently I'm reading about how a human could have dyspnea, and it's really this connection of a ventilation effort and how the respiratory centers has the disconnect of the ventilation and the sensory inputs of the efferent sensory sensation from peripheral chemoreceptors or from the lungs mechanical receptor and things like that. So usually for that we can clue into the cardiovascular systems, but that would be very unusual for a patient with a concomitant spine pain. So that could clue us into other causes of hypoxemias. And in this patient, probably the problem lies in the CVC, as Leah told us, having bone involvement with the elevated alkaline phosphatase, and especially already have a cytopenias. But now I would be very concerned about a possibly something in the bone marrows or something in the bones, something systemic with a bone disease and causing probably even anemias or other lineages, causing downs on other lineages. Yeah.
Wonderful. Oh, that's awesome. I love how you took that and you're like, hey, I think there possibly is a hematological neoplasm. I'm curious what you then think of the cough and the dyspnea. How does that layer on to that hypothesis that you have a hematological neoplasm? How would you connect those dots?
I think there's a lot of possibilities. What comes to my mind is possibly for example, if there's a hematologic malignancies, which I hypothesize maybe the patient is relatively immunocompromised. So if there's a acute onset of infections tops on the background of a malignancy, that could explain. Other than that, we can have metastasis causing lung infiltrations, like stimulating and triggers the cough receptors in the airways as well. Yeah, but I feel like cough is sometimes a non-specific symptoms and might be noise as well. But yeah, we would love to know more. Yeah.
Yeah, I'm right there with you. I think that whenever somebody develops an acute syndrome superimposed on a subacute progressive process, you have to be open to the possibility that the disease is just accelerating and getting worse, but also that the patient has suffered a complication of that disease. And so here, I think that you're trying to see like how do these things rise to the surface, either because whatever is brewing has really just reached a crisis point, or the patient has had an independent complication related to that disease. And I think a very nifty way of saying this is to say that this patient has acute bacterial pneumonia superimposed on a chronic progressive hematological process. So I think that that analysis is superb. Maybe we can zoom in on the thrombocytopenia. And I'm curious, Ethan, in general, when you hear that somebody has thrombocytopenia, what are the first questions you would want to know to further understand what that platelet count might represent? What would you want to know next?
I think I would love to know other the count in other lineages, because isolated thrombocytopenia and bicytopenia or pancytopenia have very different differential diagnosis. If it's isolated, it's commonly due to, like Leah just said, ITPs, or sometimes just a manifestations of some viral infections. But if it's cytopenia, by the cytopenias or thrombocytopenia, sometimes we could clues into the bone marrows or some hemolytic process, like in MAHA. Yeah.
Excellent. Yeah, I think you're like really studying what company is this platelet count keeping, and if it is isolated, it's a very narrow differential diagnosis. So if we just take what we have at face value, which we don't know that yet, we don't know the patient doesn't have anemia or leukopenia, but if you truly think that this is subacute for months, isolated thrombocytopenia, now that's like really narrowing the DDX, right? So what would stay on your table for subacute isolated thrombocytopenia?
Yeah, that's interesting. ITP comes to mind,
Yeah.
and other than that, I feel like probably some maybe autoimmune diseases that could first affect the thrombocytes lineages as well. Probably other lineages are not down or manifest, maybe may manifest further. But other than that, that's what's come to my mind right now. Yeah.
Yeah, I think that, isolated long-standing thrombocytopenia is very, very rare. And I think that ITP is a thought, though most patients with ITP will present a little bit more acutely. And the reason I say that is because the interventions for ITP when the patient presents will often cause the platelet count to go up. And so it's possible for sure. I think the other big one to keep in your mind is portal hypertension. And that hypothesis of the possibility of portal hypertension influenced how I was analyzing the alk phos. Because if we strictly speaking analyze alk phos, we know that it can come from liver or bone, and it's much more likely to be coming from bone when there is no other liver enzyme elevation, like AST, ALT, Billy, INR. And so the fact that it's isolated pushes us to bone, which of course is a hypothesis further reinforced by the fact that the patient is hurting in their bones. But then you have to be careful because the patient can have a synchronous bone and liver issue, and the possibility of portal hypertension, with the clue being here, the alk phos, may be at play. So yeah, I think there's a lot of information to analyze here. I think the background is unclear, the foreground is unclear. The connection may be that the subacute disease is worsening, or that the subacute disease has suffered an acute complication. And like you, I think I would tread very carefully. Is this pain a space-occupying process, i.e. imaging positive, or is it imaging negative, in which case we might have to think about nerves? Is this truly isolated, subacute isolated thrombocytopenia, or are there other more accurate ways to represent the problem? And is this true isolated alk phos of bony origin, or is this a sneaky hepatic alk phos sneaking up on us? And all those things are going to be really, really important to clarify. So why don't we hand the mic back to Leah to give us the next aliquot?
Yeah, so first, because the question came up whether the isolated thrombocytopenia was improved with treatment, they did try, I think, cortisone, and it didn't help improve the ITP, which you would expect with an ITP picture as well. So next, you get the result of the imaging that was recommended, and they found in the sacral bone, so the os sacrum, an osteodestructive space-occupying lesion of about 6 × 5 centimeters, so quite large. And it was there were multiple bone lesions affecting the entire axial skeleton with multiple osteolytic lesions. And the prostate was also noted to be clearly inhomogeneous and slightly enlarged beyond the norm. For medications that the patient took, he took hydromorphone and sultanol inhaling because he had a past medical history of COPD as well. He took lorazepam occasionally at night for sleeping. And past medical history, I already mentioned COPD and the thrombocytopenia that was noted, nothing else on past medical history. No allergies. He's an active smoker with 50 pack years. He drinks alcohol occasionally. He's from Austria, no recent travels. He's an office worker. And maybe I will give you beginning of the exams as well. He has a blood pressure of 120/60, heart rate of 108, temperature of 38.4, and he's satting 89%. He's oriented, and so to time, person, and location. The pupils exam was unremarkable. No scleral icterus, no JVP. The heart auscultation was also unremarkable, but hard to hear because he did have dry rails on lung exam. Abdomen was unremarkable. He had a painful palpation on the upper lumbar spine and also over the sacrum. And extremities, there was no edema. The foot pulses were palpable on both sides, and there was an old hematoma on the left upper thigh. And I will stop here.
Oh my gosh, wow, what a case. This one's really, really tricky to analyze in real life. So Ethan, we were maybe we can start with our previous conversation. So we don't have information on the platelet count, so maybe we can park that to the labs. But we have, I think, a lot of information on the alk phos. So what conclusions are you coming to regarding this alk phos?
Yeah, I think with the imaging evidence of osteolytic lesions, and right now we have no stigmata on cirrhosis, which is the most common cause of portal hypertension. I think we probably can make the assumptive conclusion of it being bone origins.
Yeah.
And yeah, and that makes us think about the disease process that could cause osteolytic lesions. And what comes to mind is definitely the neoplasm, osteolytic neoplasm definitely comes to mind, like myelomas, breast cancer, all these, this is a male, but in female, we think about breast cancers and renal carcinomas like that. Also like Paget's or something as well. But that is not commonly seen in prostate cancer, which Leah mentioned with the inhomogeneous patterns. So we have maybe, but in some cases of prostate cancer metastasis could cause a lytic lesion, I think, but maybe you can keep that in mind. Yeah. Other than that, I think in physical exam, we see the patient is inflamed, which is expected. And other than that, there's the only positive finding, I think, is the hematoma in the left upper thigh, which right now we might probably can make and can attribute that to the thrombocytopenia causing spontaneous hemorrhage, muscle hemorrhage. But we have to pay attention to the coax as well, because I think the internal bleeding is probably more commonly in the coagulopathy. Yeah.
There's so much richness there. I agree with your caution that most patients with thrombocytopenia present with petechiae, not deep bleeding. And so keeping your eye out for coagulopathy is outstanding. And I love your translation of an alkaline phosphatase elevation and merging that onto the bone lesion. I think I also am right there with you in the bones for the reasons you outlined, but also because we don't see splenomegaly on the imaging, which I think sneaky portal hypertension, as we've discussed in Academy VMRs, can be really, really sneaky. And so, yeah, I think that now we know we're solving a bone problem. In fact, we know it's osteolytic. So, Ethan, let's do a little bit of an exercise. So, what do you know about the function of alk phos? What is it doing in the bone? Why is it being secreted?
Yeah, I think, okay. I think it's related to the bone remodelings. And it is actually secret. Is it actually elevated in osteoblastic process instead of osteoclastic process, which is I think I remember a case from a recent IMG VMR that the fact that in myeloma sometimes alkaline phosphatase is the most insensitive markers because it's a osteoblastic lesion, but in myeloma it's an osteoclastic lesions. So I think if it's bone origin, what I would interpret that would be increased bone remodelings, like new bone formations. Yeah.
Exactly right. Superb. So you can put bone lesions on a spectrum from pure blastic to pure lytic, and most things fall in between. Pure blastic disease tends to be prostate cancer, though there are versions of prostate cancer that bleed into the mixed category, where a patient has really high alk phos and no evidence of bony destruction. It's all blasts. Multiple myeloma is on the other end of the spectrum, where there is a pure lytic component, and the vast majority of patients have a normal alkaline phosphatase. That is, of course, unless they cause a pathological fracture, and the pathological fracture triggers bone remodeling and alkaline phosphatase secretion. So I would say the combination of labs and imaging tells us that this is a mixed process, with the imaging suggesting lysis and the labs with the alk phos elevation supporting bone formation. Now you might ask, why is this helpful? And I will share with you some processes that tend to inhibit bone formation and are less likely based on the finding of an elevated alkaline phosphatase. The first is bone infections, osteomyelitis. Even though this patient is febrile, which is going to push us to think about osteomyelitis for sure, the presence of an alkaline phosphatase elevation is an argument against osteomyelitis because infections tend to halt bone formation. It's also pretty interesting, the two most notorious autoimmune diseases that cause bone destruction, namely sarcoid and histiocytic diseases, also tend to actually suppress alk phos secretion. And so I think you have to be careful not to extract too much information out of a subtle clue and say this can't be an infection because the alk phos is high. But I want all of you to query all the patients with osteomyelitis you've taken care of. Of the back or of the foot, their alk phos is usually completely normal. Now you know why. It's a pure lytic destructive process. So I think we can get some juice, Ethan, out of the paradox of lysis, but evidence of blastic features, to lower the probability of infections and to lower the probability of autoimmune diseases like sarcoid and histiocytic diseases. But these are still, of course, on the table because this clue is a soft one, not a robust one. And so, Ethan, if we step back and say, okay, I know I have a patient with a bone lesion. How do you think about approaching that space in general? Like when you have a patient with bone lesion, what progress would you like to know? What other information would you like to know?
Yeah. I would like to know if it's single or multiple, because if it is a bone tumor, it probably singles, and if it's a single lesions, I would lean on the expertise of radiologists because usually there are some subtle clues that could clue us to the diagnosis. But if there's multiple, I would think about uh, the diseases I mentioned earlier, like osteolytic neoplasms, or sometimes I think there's other infections as well that could cause multiple lytic lesions, probably not very common. Like I don't know if TB would cause it or some granulomatous process could cause it. But and then the disease you mentioned in autoimmune disease categories. Yeah.
Yeah, 100%. I completely agree with that. I will help you simplify it even further. The first question to ask with a patient with bone lesions is, as you said, multiple or single. And then the second question is this primary bone disease, or is there evidence of a metastatic focus? The vast majority of bone diseases that are sinister in nature are not primary bone disease. They are TB going to the bone, sarcoid going to the bone, prostate cancer going to the bone. So it's really, really important to ask that question, because biopsy of bone is disappointing. Even when you know that there's something right there destroying this bone, getting high quality tissue to analyze for pathology is much more disappointing than lymph nodes and masses and whatnot. So it's so important to recognize that the yield of bone biopsy is much lower than other places that we biopsy. So what I'm really trying to do is to say, is there an extra bone focus of disease? And that question is always influenced by the fact that there may be distracting disease elsewhere. Just because somebody has a seborrheic keratosis on their skin and has a lytic bone lesion doesn't mean that this is a metastatic seborrheic keratosis, right? And so you can take that to say, well, is the prostate here relevant or not? And I think that that becomes really, really tricky. So what's often really helpful to find actually is to find another site of metastatic disease, not another site of primary focus. So if this patient has a lung nodule is tricky, could be completely benign. But if this patient has a large liver mass, benign liver masses are much less common than prostatic hypertrophy and lung nodules. So I think the question in this patient is this problem an isolated bone problem, or is this a bony problem with evidence of distant disease elsewhere? So what thoughts do you have about where the distant disease might be if it is present? What do you think about that?
You mean in this patient?
Yeah, in this patient.
Yeah, there's signature in the lungs, but I feel like it's probably too conclusive to make a connection right now,
right?
Because it's a probably very possible it could be a superimposed infections. But other than that, probably not. I don't think there's other clues. Yeah, I think the examination findings of dry rails, if that's not focal, I probably think a more systemic involvement, because I would expect a more focal findings in a bacterial pneumonias or some acute pulmonary infection.
Agreed. I completely agree with you. I would just share the piece of advice that it's very tempting to lump in thrombocytopenia or bone marrow diseases under bone diseases, but they're very different. So for me, in addition to tracking the lungs and the prostate, I think invoking the bone marrow because of the thrombocytopenia and separating out from the bone lesion, because a bone lesion alone should not cause a thrombocytopenia. So I would just advise all of you to remove the low platelet count as a separate category and not accidentally put it under the bone lesion. So I think that's the question, Ethan. Before we try to solve this problem, we have to represent it. Is this an isolated bone disease, or is it a systemic disease with bony manifestations? And I think there's a lot of fingerprints of a systemic disease with the fever, the rails, and the thrombocytopenia, and we'll see where they take us. Alrighty, Leah, back to you.
Okay, I love the discussion, especially also with the clues for osteoblastic or osteoclastic bone lesions. Very interesting. And let me continue with the labs now. So he had a white blood cell count of 12, a hemoglobin of 9, and platelets of 35, so even a little lower. MCV was 98, and he had on diff erythroblasts and normoblasts. CRP was elevated at 88. The electrolytes, including the free and total calcium, was normal. Phosphate was also normal. Kidney and AST was normal. ALT was only slightly elevated. Albumin was 3.9. Total protein was normal as well. LDH was 384, with the upper normal being 240. The total bili was 1.9. And ALK-Phos was 2,103 in this patient. And INR was 1.4, and APTT was 31. Now, this was the labs. I'll just give you a bit more of history. or of the clinical course, he was given antibiotics because there was also suspicion for bacterial pneumonia in this patient giving on his presentation. And the cough and the pulmonary symptoms actually improved, and the CRP also decreased over the course. There was a ultrasound of the abdomen that was done. The spleen was measured 11 centimeters, and there was no indication of any metastases or lesions in the liver. And I think I will stop here.
That's amazing. I'm just gonna ask just one clarifying question, Leah. I always forget what the normal limits of the PTT is. Is that slightly high, I would guess, or on the
That is normal.
that's normal. Okay. Okay. And then is the spleen size normal as well? I forget what normal. Okay.
Yes, 12 would be upper.
Gotcha. Alrighty, perfect. So Ethan, what happened there?
Yeah, very interesting. So the high blood cell count is in line with the inflammatory pictures, and then we have anemias and probably I would say moderate to severe thrombocytopenias with erythroblastosis. And I think I recently read about an article that erythroblastosis means there's like the immature RBC being produced and released in the peripheral blood. And that would definitely make us more lean into a bone marrow process, or otherwise it would mean a very significant stress that was put onto the bone marrows. But other than that, I feel like with this such a low platelet count, along with elevated bilirubin, we have to rule out malignant MAHAs, macroangiopathic thrombolytic anemias with a peripheral blood smear as well. And then, yeah, I think that's probably my initial thoughts. And with the improvements of antibiotics on these pulmonary symptoms and decreased CRP, now we probably lean more into a acute superimposed infections of the lungs right now. But I think it would be helpful to give it a chest X-rays. Yeah.
Yeah, I completely agree with your conclusion, and you're seeing Leah's masterful presentation about like showing us how valuable it is that the lung stuff was tucked in. And I think your initial hunch that it's a complication of the disease process. And I think now it's easy to say that your hypothesis of immunosuppression based on bone marrow disease is bearing fruit, and the patient has concern for bone marrow syndrome that has left him relatively immunodeficient. And so I think we can put the lungs aside, and so we're left with. Actually, maybe I can ask you, like, maybe you can sort of summarize. What are you left with now? How would you summarize the relevant pieces of this syndrome? How would you describe it?
Yeah. So I think what I frame this problem would be a mixed lytic and blastic bone diseases along with bone marrow involvement. But right now I don't think we can. Probably there's connection like a bone marrow disorder with expansion to the bones, or probably there's separated problem as you mentioned with being a manifestation of a metastatic diseases. Yeah, I think that's it. And otherwise there's other clues in the prostate, but maybe keep that in mind and give it and measure a PSA would be helpful. Yeah.
Yeah, oh my God, I'm so glad you said that. I'm so glad you said you want a PSA. You know, as you guys know, I try to be very, very precise about defining the problem, but my heart is dying for a PSA, and I think I'll try to explain why. So Ethan, I get to have a little bit of revenge now because I remember when you presented a case of Maha with a liver cancer and a tumor thrombus, and I was so stumped. But because of that, I learned so much, and I think the word Maha is such a powerful word because it really is microangiopathic hemolytic anemia. Microangiopathic. Now, what does microangiopathic mean? It means hemolytic anemia in the small blood vessels. And I encourage you all to actually use the term MAHA not to mean microangiopathic hemolytic anemia, but to actually mean one of three things that all start with an M. So Ethan, when you presented that case of an HCC invading the IVC, causing turbulent flow and causing hemolysis on that tumor in turbulent flow, that was a macroangiopathic hemolytic anemia. That's the same kind of hemolytic anemia that patients with prosthetic valves have, or it's hemolytic anemia in the large visible blood vessels. And then, of course, there's microangiopathic hemolytic anemia, which is TTP. That's 2 of the 3 M's. What's the third? Marrow. In situations where you have abnormal red blood cells in the marrow, you can actually get a pseudo microangiopathic hemolytic anemia or a marrow angiopathic hemolytic anemia, as evidenced by the several cases we've had of B12 deficiency causing schistocyte appearing lesions, but those are really just abnormal red blood cells in the blood, in the bone marrow, excuse me. So I think whenever you're suspicious of a MAHA and you have bone marrow disease, the likelihood is that the red blood cells are actually being destroyed in a very dysfunctional marrow. And that dysfunctional marrow can be dysfunctional because of B12 deficiency or myelodysplasia or even acute leukemia. But Ethan, let's practice some reflexes. Okay, reflex. Marrow disease plus DIC. When I say marrow disease and DIC, what reflex?
Yeah, acute promyelocytic leukemia.
Exactly right. Let's not forget that INR, it's 1.4. But you have, whenever you see this, you have to think, is this acute promyelocytic leukemia? But I think the answer is probably not, because the patient has had subacute symptoms for a long, long time. So then the question becomes, well, do you have to think about this patient having a microangiopathic hemolytic anemia beyond the very presence of coagulopathy? Because whenever you're thinking MAHA and you see a coagulopathy, you should reprioritize your differential diagnosis to DIC. And so for me, I'm now framing this problem, Ethan, as a patient who has a bone marrow disease, who has bone lesions, and who has concern for DIC. And that I cannot wait to hear the D dimer. I suspect it's pretty high. And the fibrinogen, which I don't suspect to be very, very high. But all of you might be thinking, wait, hold on. DIC, this has been going on for months. Is there a subacute to chronic form of DIC? That's the question I think we're facing. Ethan, do you know anything about long-standing or subacute DIC?
Honestly, I don't, but I feel like if there's chronic endothelial stimulations causing microthrombi formations, would cause that. I think in a background of, I think malignancies or some maybe vasculitis probably could not be that chronic, but I think probably it's based on pathophysiology would be what I suspect. Yeah.
I think that yeah, I think that that's beautiful pathophysiology, and I'll just leave it at that. Because I know we have more data coming our way, but I think bone marrow, DIC, and bone lesion. Now, Ethan, ask yourself, how many patients with bone marrow disease have you had on VMR, seen in real life, who have a large bone lesions in their axial spine? Would you say uncommon, common, expected? What do you think?
I don't think that is very common.
So the overlap here of bone marrow and bone, even though the words are so similar, is actually a profound filter. So honestly, if you say the problem representation is a bone marrow disease with coagulopathy and with bone lesions, you're leaving very small number of things left in the differential diagnosis. Very small number. Especially when you start to say the patient has subacute DIC, such a small number of things. And I don't think we need to go through that differential now, because I think we have more information, but I would just articulate the following key principles. A bone lesion is very different from a bone marrow disease. Don't lump them in together. Patients with DIC are often acute and either as a result of a life-threatening infection or an aggressive manifestation of a malignancy. There are subacute versions of DIC, which we may talk about at the end if the case goes in that direction, but I think we need the rest of the DIC panel, the D dimer, the fibrinogen, to even expand on that hypothesis. And the combination of bone and bone marrow is usually a very, very small space. And so, yeah, well, I think we have 20 minutes left. So why don't we hand the mic to Leah to see what you have prepared for us.
Well, it's so interesting to listen to you, and I think now I would love to go back and look at 10 more pieces of data now that I have all of your discussion points. First, I think I will give you the PSA because both of you mentioned it. So the PSA in this patient was a normal. And the retic proliferative index that I calculated was hypoproliferative. And the serum electrophoresis and kappa lambda ratio was also normal, as well as the ESR for this patient. And there was a peripheral flow cytometry done, which showed myeloid precursors of unclear origin. That was how this was described. And I will also give you the blood smear now, which showed a left shift to like precursor cell to blasts around 5%. And in addition, discrete signs of dysplasia of the granulocytes, increased normal blasts, a Luke erythroblastic blood count was the summary. And then the PET-CT, which we actually were lucky to get quite early in the course for this patient, showed signs of central and peripheral bone marrow activation. There were bone lesions in multiple areas, including sacrum, ribs, sternum, femur, with mixed osteolytic and osteoblastic lesions, as you already discussed. Increased uptake also in a consolidation in the right lower lobe of the lung. There were no mediastinal or hilar lymph nodes that were remarkable on this PET-CT. And I think I will stop here. There will be one more aliquot, and then I will reveal the diagnosis.
Wow, thank you so much, Leah. Very, very intriguing. All right, Ethan, what updates do you have to your thinking here?
Yeah, so the PSA is normal, so that's good. And then we have a hypoproliferative reticulocyte index, which means the bone marrow is not working functionally. And then SPEP is normal, so probably could rule out the disease that could cause monoclonal gammopathies like myelomas. And other than that, we have a significant leukoerythroblastic reactions from the blood smears and dysplasia from the granulocytes. So seems like there's dysfunctions in the productions in the myeloid lineage, and then combined with the PET-CTs of like extensive bone marrow activities. Yeah, well, I think we're moving in directions of leukemias or lymphomas.
Yeah, I'm right there with you. I think it's hard not to worry about this patient, hard not to worry about a malignancy doing this. And if we just sort of center ourselves, Ethan, you heard a red flag word, you heard the word blasts. So if you were to ask yourself, what does that mean when you see blasts in the periphery? How would you break that down to somebody you're teaching who doesn't know this concept?
Oh, okay. So blast is a immature white blood cells in the very early immature cells, like a baby of white blood cells. It could be due to like extensive peripheral destructions. Like if you can think of a severe infection stimulating the bone marrow to product that. That could cause left shift and blast as well. But then there's another possibilities of mutation caused in the cell itself, causing monoclonal proliferations, and that would be the case in cancers. Yeah, probably that's the two most common mechanisms.
Exactly right. Even if you have blasts in the periphery, they might be completely normal blasts being pulled into the periphery by a severe stimulus, like a severe infection, or as we see commonly, the receipt of GCSF, a bone marrow stimulating molecule. You might have blasts that are coming from the bone marrow being pushed out because they're abnormal and they're mutated, or that there's a space occupying bone marrow process that forces them out. And so here, Ethan, I think there is no strong peripheral trigger. There's no severe infection. There's no GCSF.
So what's your sense? Do you think that this person has a primary bone marrow mutation, or that there's something crowding the marrow, forcing those cells out? What do you think?
And probably primary bone marrow lesions, because we could appreciate some clues in the blood smears, like schistocytes or teardrop cells, signifying the infiltrations and crowdings of bone marrow. Although that is not 100% sensitive. Yeah.
I agree with you. I think that the lack of evidence of the cells being crowded out in the form of teardrop cells is definitely an argument against an infiltrative bone marrow process. The argument for it is the prominent peripheral fingerprint of disease outside the bone marrow. So what's beautiful about leukemia is it tends to stay in the blood for most people. And in a small fraction of people will cause lymphadenopathy, splenomegaly, and maybe even bone lesions. But the number of people who have what's called myeloid sarcoma, where they have leukemic cells outside the blood, is pretty low. So you have this tension. You have a prominent amount of extramarrow disease in the lungs, in the bone, which suggests that whatever that is causing the bone lesion and the lung lesion is going to the bone marrow, because traffic going the other way, leukemia to bones and lung, is pretty unusual. Tempered by the fact that the patient is having no signs of teardrop cells. I worry, my prioritization initially would be that I worry that this is a process invading the marrow because of just how much axon is happening outside the marrow. And in particular, I worry about the lung focus because of the patient's 50-pack year smoking history. And so could this be metastatic cancer of pulmonary origin? To tell you the truth, until 2 or 3 months ago, I had never seen anybody present like this, but I actually met a gentleman who had an ALK phos over 2000. Who had metastatic lung cancer to the bone and bone marrow. So I think, long story short, Ethan, your schema is gonna be what guides us to the answer here. And I think we're not thinking about something outside the marrow like an infection or GCSF. We're thinking something taking up space. And the question is it a mutated process or an infiltrative process? And the sheer weight of extramarrow signal has me concerned that there's something invading the marrow, likely malignant. But of course could be infectious, could be histiocytic, could be many other things. My only piece of advice is to recognize that the yield of a bone marrow biopsy for myeloptosis is only 50%. Patchy disease is often hard to find. In stark contrast to the yield of leukemia, which is much higher, it's a homogeneous disease. And so be prepared for the bone marrow. If it tells you it's leukemia, it's leukemia. If it tells you, I don't know what's going on here, recognize that when processes infiltrate the marrow, they do so in a patchy, sneaky way. So I think you're right. We need a marrow, and I'll, for the sake of time, pass the mic to Leah to see what the next aliquot is, and we'll go from there.
Yeah, the diagnostic process for this patient was really challenging because it was trying to, like, for us, everything was like screaming malignancy, like from the beginning. But then where do you find the tissue or what it actually is? And you have these clues. And for me, it was also the first time I had a patient with this kind of blood constellation as this patient. And one approach was, okay, osteolytic and osteoblastic, which cancers could do both. And there were several that the oncologist suggested, but amongst them were also lower GI cancer. So there was a rectosigmoidoscopy also done for the patient, which was unremarkable. And then because of the lung nodule that was also uptaking, we were thinking, with this smoking history, could this be lung cancer? The bronchoscopy, unfortunately, also did not show anything besides chronic bronchitis for this patient. And then it was clear that we had to examine the bone marrow as well. First, there was a bone marrow aspirate that was done, which only showed the same thing as the smear. So basically, there was a leukerythoblastic cell pattern. But then a CT puncture was performed. Fortunately, it was possible after several attempts because of the low platelet count. It was hard. He had to get concentrates, and once it didn't work, and then so it was also kind of hard to actually get the diagnostic necessary for the patient. But once this was done, the CT puncture of the iliac crest showed formations of an adenocarcinoma with partial signet ring cell morphology in this patient. And after that, because of the signet ring cell morphology, an upper endoscopy was also done for the patient, which showed no clear malignant lesion. And there was one biopsy taken of maybe a little erythematous region that could have been slightly suspicious. The histology was also unremarkable for this patient. And just for completion's sake, syphilis, quantiferon, B12, and folate tests were unremarkable. And that's the last aliquot.
Thank you so much, Leah, for outlining the very tough reasoning in this case, and not like the difficulties in deciding where to biopsy. I think it's really tricky, and to also teach us how getting a bone marrow in somebody with pretty low platelets can be very, very challenging. So Ethan, what are you thinking now?
Yeah, I think I'm completely humble. I especially love the tension of. I think it's like a egg and chicken theories of either it's a metastatic disease primarily from other part of the bodies, which in this case we have signatures in lungs and bones in like disease like osteosarcoma, an invasion to the bone, or if it's a bone marrow disease expansion out to the bones and causing metastatic disease. I think, and we have to evaluate the tension, the clues that the patient give us and the labs to like see where is the center of gravity. And I think in this case, like the alkaline phosphatase is so elevated, so probably that would clue us a extra bone marrow diseases. But I think I found it very interesting that in signet ring cells, I don't have a knowledge on that, but what I have remembered is that it usually is from stomachs, like in plastics or undifferentiated GI cancers. But interesting that there's no clues in the histories that could clue us to that. So I think that's a humbling part of this case.
I completely agree with you. I think, Ethan, we're treading on a syndrome called cancer of unknown primary, and I'm very grateful to a very frequent VMR attendee on Fridays, Mike Santos, who actually presented a case in written form of this condition. It was actually my first ever written discussion. It brings back a lot of memories. But essentially, the entity of cancer of unknown primary is that in some very unfortunate, often very aggressive cancers, the cancer is so dedifferentiated and so mutated that you actually don't know for sure where it came from. And of course, that is a diagnosis that is very, very hard to make definitively, because you wonder if you ever, like, if you can get more and more information or technology to clarify that. So I think the staining on this on the bone marrow sample may allow you to clarify the origin, which of course I don't remember, but that's a very, very powerful tool to help you say, hey, I think this is where it came from. And I think the reason it matters where it came from is because if you actually further label it as metastatic blank cancer, the treatments then get tailored to whatever the origin is. And more there are protocols for cancer of unknown primary, and the patient gets treatment for that. But the more and more information you're able to get about the cancer, the more precise and accurate your treatment can be. So that's the impetus to try to clarify what this is. But I think I would just share that the syndrome of cancer of unknown primary exists. It essentially involves such dedifferentiation and regression at the primary site that the tumor is actually no longer at the primary site. But it dedifferentiates so much and regresses locally and spreads widely elsewhere. And I haven't reviewed this topic for a while, so I'm using aging neurons to share with you what little I know, just that it exists. But I'm excited to either I'm going to read about it anyway, whether or not it's the final diagnosis. But I think that's probably the next step that I would be thinking about is, can we characterize this tumor more precisely histopathologically to help us figure out where it came from. And even if it helped us figure out where it came from, we might not find it at the original site anymore. But yeah, Leah, Mike to you. What an intriguing case. I can't wait to learn from you.
Yeah, I love the discussion. And I think this case is still so, like, it makes me think so much because I wish there was an easier way, or maybe is there some clear test or path that I don't see that could lead us to the diagnosis for this patient. But I think, as you mentioned, so the final diagnosis or label this patient got was a cancer of unknown primary with bone marrow carcinomatosis. And carcinomatosis, bone marrow carcinomatosis basically means a non-hematologic malignancy that invades the bone marrow and is basically a metastasis then to the bone marrow. And the Cygnett ring cell morphology, the only association I had before was, okay, it's associated with gastric cancer that can have it. But then I was reading up, and basically it's a sign of poor differentiation, as you also discussed, and also of poor prognosis, unfortunately, and is associated with several types of cancer, but stomach and colon cancer are two of them. And a bit of the clinical course more for the patient now. So there was a little bit more testing done. They did molecular tests on, because then afterwards, after the CT biopsy was transferred to the oncology unit, and they did molecular tests which didn't yield any concrete diagnosis, but they decided to do no further testing afterwards because of the progressive thrombocytopenia actually for the patient. There was no suitable therapy, so there was no consequence of the testing. Unfortunately, there was even a further increase of the myeloid precursor cells in the blood and the normoblasts and organ dysfunction. Platelets were down to 15, white blood cells increased, LDH also was highly increased. And I just followed up now from the chart from what I was reading because he wasn't here anymore, but now the blood smears showed actually schistocytes, which also for me, it was actually really helpful because shortly before I listened to the Academy of the Maha and first heard of the concept of bone marrow Maha basically, and which was one of my hypothesis why he then developed also schistocytes in the course, which were not seen initially because this was like rapidly progressive, but a progressive disease. So first, not everything had yet developed. And if you guys want, I have a bit information. So my main teaching points for bone marrow metastases, because this is a new concept. And what I tried to do with this case is kind of prime ourselves so we recognize this pattern again, because I wish I knew what to do with erythro and normoblasts in the beginning. And now I think this can be more familiar now that we heard it. But basically, when should we consider bone marrow metastasis? So consider it in tumor patients or in suspected tumor patients, because we had this tumor screaming all along for this patient. Consider it in unexplained or progressive persistent cytopenia, especially if low platelet or low hemoglobin counts. Consider it in leukoerythroblastic cells in the peripheral blood, as this patient had. And also, if there's an abnormal elevation in ALK phos and LDH, which both this patient had. And so basically we can ask which cancers can do this. Basically every solid tumor that can metastasize hematogenously has the potential to have a bone marrow metastasis like this. But the most frequent ones in adults are breast, stomach, prostate, and lung. And maybe just one remark is, I think from one of the VMRs, I think Reza discussed this, but very de-differentiated prostate cancers can actually end up having a normal PSA as well. So I was wondering, of course I don't have the answer, but this is just something that made me think also in the case of this patient. And so basically you want to go to the bone marrow examination to get the diagnosis. And biopsy is always better than smear because, as was also discussed, there are focal patchy tumor deposits. So the yield is higher and also not 100% if you do the biopsy. And yeah, I think I don't want to say too much because then it's too much and less sticks, but maybe just let us consider what is the image of bone marrow metastasis, weird cytopenias and precursor cells in the blood in diagnosed or suspected tumor patients.
Gosh, you guys are incredible. I mean, I can't believe that, yeah, you just basically simplified such a complicated concept to like its core principle at the end, which was absolutely superb, decorated with a lot of very valuable information. And I think the quality of the presentation here, I think, stands on itself, like the not ignoring the cough and the shortness of breath and then tucking them away, giving us the alk-phos and the thrombocytopenia to work with at the beginning, setting us up for a conversation about the heme and the bone from the very beginning, and then adding to each of those categories along the way was just amazing. It was for a very rich hour. And I think in parallel, Ethan, I mean, I just sit here and I was thinking the same thing yesterday after doing Thursday VMR with Ella. Like, you guys have no idea of just how outstanding you are. I think it's just the norm for you, and you're of course surrounded by people who are doing the same. But me being in your shoes it's not a very distant memory. And I think your ability to articulate yourself, Ethan, and to explain why you're thinking and to update your thinking when given more information is just unbelievable. That was outstanding. I hope you had a good time. How do you feel now at the end compared to the beginning?
Yeah, I feel like when the discussions progress, the nerves, like the symptoms bleed a little bit. Yeah. But yeah, I want to add a comment on the case. I think the most surprising part is that in this case, it's likely to be a non-bone marrow origins. But probably what I would like to learn after the session is that there's just so less there's literally no signal in the primary origin. If you're considering a very like a cancer that metastases to the bone marrow with this kind of progression, you would probably kind of expect some signals from the primary origin, but in this case there is not. So I wonder if there's some kind of cancers that has this kind of akin to the bone marrows. But I love the prostate undifferentiated pro-cancer hypothesis, and probably if I take a vacation, I would probably like look more into that. Yeah, and I want to thank you, Leah, for the amazing presentation and the amazing case.
Agreed, Ethan. I think it's a very, very telling combo for sure. Sorry, I have to apologize to you. I just made you the host. That's because I have to leave now to make it on time for work, which means hopefully more and more fun cases to share with you all in the academy sessions. But take it away, my friend. And when you're done, please end the meeting so that, yeah, so that we're not listening to your private thoughts thereafter, which I have done, by the way. Bye, guys.
All right. Ethan, my friend, cheers to every bit of caffeine keeping you alive at 1 a.m. This was amazing. Let's go and learn a lot. This was a complex case. Thank you, Leah, so much for the presentation. This was amazing. So, there are two primary things that I want to focus here for the teaching points. First was the osteolytic lesions. We understood that when we see these kind of lesions, we need to think about two categories of diseases, blastic and lytic lesions that can lead to the initial presentation of an osteolytic lesion. Pure blast, these are on a TAFE, and the diseases are often mixed, and we need to remember that. Uh, on one side, we have pure blastic diseases like prostate cancers that can sometimes present as mixed. On the other side, we have pure lytic disease like multiple myeloma, of course, without a pathologic fracture. In cases where we have pure blastic disease or we are more on the blastic side of things, we will usually see an alk phosphatase rise. On the other hand, on the other side, we don't usually see it. So something to differentiate them. And before moving on into how we approach this lesion, we need to remember the 4 P's of bone lesion. Shout out to Mark in the chat. PTH, paraprotein, RPR for syphilis that can lead to osteitis, alk phosphatase, and PSA. It will cover many of the things that we're going to be thinking about when we are going to be approaching these lesions. So how do we approach them? First, we need to see if there's multiple lesions or single lesion. And to understand that, we want to frame it as bone disease itself versus distant disease. And remember, when you're saying bone disease, you don't mean bone marrow disease. This is a separate category, and we need to think about it separately. So what do we mean by distant disease? Usually it's sarcoid, TB, and cancer metastasis, which in this case we saw it. And we need to remember that biopsy in these cases is usually disappointing. So we're going to be looking for external focus of disease to help us identify the final diagnosis. Now let's approach the hematologic findings that ultimately lead to a diagnosis of cancer of unknown primary. First, we saw thrombocytopenia, which by and of itself usually points to many processes. It's an unspecific, but it being in isolation can lead us to something like MAHA, especially considering that considering the other hematologic findings we saw there. When we're thinking about MAHA, we need to think about 3 M's: macroangiopathic hemolytic anemia, microangiopathic hemolytic anemia, like in TTP, and final M, marrow, which points to ineffective erythropoiesis. In these cases, mutations in the marrow lead to ineffective production of RBCs, in which we may see blasts. Here we saw blasts in the periphery, which points to baby RBCs, as Ethan put it brilliantly. In these baby RBCs can either be pointing to extensive peripheral destruction, which has stimulated the marrow to produce more and more RBCs, or it is pointing to them being pushed out, either due to infiltration, space-occupying lesion, or mutations that had caused monoclonal proliferations. Combining these findings together, we see external focus of the disease, and we don't see the marrows crying, as Prof. Rez always puts it. When we see teardrop cells in the periphery, it means that marrow is infiltrated and is crying for us, but we don't see it here. So our primary focus is going to be metastatic cancer, and what we saw here was a cancer of a known primary. And in spite of increasingly sophisticated diagnostic workup, as Elena mentioned in the chat, 3 to 5% of metastatic tumors remain unrecognized for their primary site of origin. Here, the finding of sickle cell carcinoma points to poor differentiation and aggressive behavior, which points to poor prognosis and late diagnosis. Usually these arise from gastrointestinal tract, but as Leah put them, basically anything that can metastasize can lead to this presentation. The most common of which being breast, stomach, prostate, and lung cancer. One thing to remember here is that prostate cancers can present in the context of a normal PSA in this setting because they have differentiated. Finally, when should we consider metastasis? Basically, any time that you are considering a tumor or a patient is suspected of having a tumor. Other times include a progressive rise in alk phosphatase or LDH, progressive cytopenias or unexplained cytopenias, and finding of leukoerythroblastic cells in the periphery. Thank you so much, everyone, for the great discussion and for the great teaching. Thank you so much, Leah, for the great case. I learned so much.